Hello to everybody. My name is Stefano Taddei, and I am professor of internal medicine at the University of Pisa. I'm here to speak with you because I am the chairman of the webinar entitled Hypertension, Novel Treatments and New Positioning of Beta Blockers in Cardiovascular Management, which will be held on Friday, 20 June 2025. And in this webinar will be discussed some issues related to hypertension and hypertension control, specifically related to the positioning of beta blockers in the treatment of cardiovascular disease, the method to measure blood pressure, and the novel therapeutic approach that will be available in the next future.
How did the previous guidelines position anti-hypertensives?
Previous guidelines were very clear in positioning anti-hypertensive drugs. European Society of Hypertension and the European Society of Cardiology guideline, they just suggested to use the main four anti-hypertensive drug classes, including RAS blockers, ACE inhibitors, or AT1 receptor antagonists, calcium antagonists, diuretics, and beta blockers. Why four drug classes? Because the main target of antihypertensive treatment was considered the lowering of blood pressure values, because it was supposed this is the best way to reduce cardiovascular risk. In the more recent guidelines, both societies decided just to propose as first-line drugs RAS blockers, calcium antagonists, and diuretics used in combination, the RAS blockers plus the calcium antagonist, or the RAS blockers plus the diuretic. And beta blockers were reserved only to specific situation, clinical situation. Now, in the last guideline released by the European Society of Hypertension, again, beta blockers are in the first line. And okay, we always have the indication to start with the RAS blocker plus a diuretic or a calcium antagonist. But you have also the possibility to consider beta blockers as first-line drugs and use at any level of the anti-hypertensive treatment, because beta blockers are effective and they have many clinical conditions in which the use of beta blockers is mandatory, the so-called compelling evidence. And I just would like to quote tachycardia, coronary artery disease, heart failures, headache, especially migraine, atrial fibrillation, palpitation, panic attacks, pregnancy. So many patients could benefit by the administration of a beta blocker.
Describe the newer, more reliable and exact BP measuring available to effectively identify and monitor people with hypertension.
Oh, this is a really good point, because after all this year and all the evidence that consider hypertension as the most important cardiovascular risk factor, because I like to remind that hypertension is the first cause of death around the world, according to the data of WHO. Still, we don't know exactly how to measure blood pressure values. Okay, we have three different methods which are validated and proposed by guideline. We have clinical blood pressure, which is blood pressure measured in the hospital, in the clinic environment, by a doctor, by a nurse, and this is the clinic blood pressure. Then we have home blood pressure that now is possible to do because we have very affordable and useful automatic devices validated. So for the patients, it's very easy to measure blood pressure at home. And finally, we have just more sophisticated technique, which is the 24-hour blood pressure monitoring, which allow to measure blood pressure along the whole day and the whole night. Also, should be easy to know what is my blood pressure value. This is not so, because in many situations, blood pressure can change, and even the three techniques can give different results. First of all, it's necessary to underline that clinical blood pressure is the reference measurement, because all we know about hypertension, we know by the utilization of this technique. So epidemiological studies defining hypertension as a cardiovascular risk and the threshold of the definition of blood pressure, for instance, 140/90 millimeter of mercury, were obtained by the utilization of clinical blood pressure. And all the intervention studies, the so-called controlled clinical trials demonstrating that blood pressure reduction is associated to a decrease in cardiovascular morbidity and mortality or total mortality. Those results were obtained by clinical blood pressure. But in the clinical practice, when I face the single patients, sometimes it's difficult, especially in our offices, to have a reliable blood pressure measurement, because we need time, there is the white coat effect. So we can use home blood pressure. Home blood pressure can be very useful because the patient is motivated to follow his disease, but there is also the problem that sometimes the patients measure blood pressure values incorrectly. And we have also to say that while blood pressure normality is at 140/90 millimeter of mercury with clinical blood pressure, if I use home blood pressure, the target value is 135/85 millimeter of mercury, because I don't have the white coat effect. Finally, ABPM, ambulatory blood pressure monitoring, is very useful, but it's not easy to do, is cost effective. And finally, in many situations, is not very reproducible, also because many patients suffer this technique. For instance, they don't sleep during the night because the automatic device causes noise. And so with each technique, I don't have a real affordable result. In many situations, we have to use all the technique to rise, to have the possibility to do a correct diagnosis of blood pressure values in our patients.
What novel treatments are being explored to treat hypertension?
In the next future, we have some new possibility to treat hypertensive patients. We have new drugs. We have drugs that we already use in the clinical practice that can be used in hypertension, and we have a new technique using devices. The new drugs are especially drugs targeting aldosterone. So we have a new aldosterone receptor antagonist with much lesser and lesser side effects as compared to spironolactone. Spironolactone is a good drug, but the compliance to this substance is very low because of side effects. New anti-aldosterone new aldosterone receptor antagonists are much more selective, and their chemical structure is different from spironolactone, and especially phenyrenon will be useful, can be used for the treatment of hypertensive patients. But another novelty in the aldosterone field is the possibility to use very selective aldosterone synthase inhibitors, so drugs which block the enzyme which produces aldosterone, and the molecule is called baxdrostat. So using these new drugs, we could really be more effective in blocking aldosterone effect. Probably the most intriguing and interesting possibility will be zilebesiran. Zilebesiran is the first RNA-based approach to target angiotensinogen. Because zilebesiran is a siRNA, so a molecule which can silence RNA messenger for the production of aldosterone. So at the hepatic level, this drug can totally reduce the production of angiotensin. The preliminary data are very interesting. The drugs seems to be very effective, well tolerated, but in my opinion, the most important thing, if this drug will be available for the clinical treatment of hypertensive patients, we will have the possibility to do only one injection every 6 months. So one of the biggest problems in hypertension, which is compliance, can be absolutely resolved by the possibility to use drugs who last 6 months. Another possibility are the antagonists of endothelin receptor, ETA and ETB receptors. We have already one molecule available, which is aprocitentan. The antihypertensive effect doesn't seem to be very strong, but we have only one study in patients with resistant hypertension. So possibly the clinical utilization will be it will be more important to assess the clinical utilization in other kind of patients. Then we have drugs that we use for other diseases, including, for instance, SGLT2 inhibitors, glyphosine, that have demonstrated to reduce blood pressure values. And this is one of the explanation for their beneficial effect, not only versus diabetes, but even more important, versus cardiovascular disease, including heart failure. Another very strong antihypertensive drug is sacubitril/valsartan, that is very, very effective in reducing blood pressure values. Up to now, we don't use in hypertension because the drug was not registered for this kind of disease. But when the patent will expire and we will have the generic compound with the lower price, we will use this drug in hypertension, and this is a very, very potent compound. Finally, we speak since more than 10 years about renal denervation, but now really this technique is applied in hypertensive patients because we know better the technique. The method has been improved. The new catheters are much more effective and easier to use, and the experience is increasing. And again, this is a technique which can improve, can resolve the problem of adherence, because the technique is effective and there is no the necessity to take drugs. This is an interventional technique, and there is not the need to take drugs to lower blood pressure values.
What take-home messages do we have at the end of this interview?
Take-home message are that hypertension is not just lowering a number. Hypertension is treating a patient. And so we have different conditions. Guidelines speak about high blood pressure values. We see patients with comorbidities, with side effects. So first message, we are being very good to use all the drugs we have and not just to sing to 2-3 drug classes. And in this situation, beta blockers can help in many specific situations. Blood pressure measurement is not so easy as everybody believes. We must be very careful. The clinical condition must be accurate, and the doctor should be very good to use all the 3 methods that he has available: clinical blood pressure, home blood pressure, ABPM. And finally, in the future, we will have new drugs, very interesting drugs, blocking aldosterone receptors or aldosterone synthase, blocking endothelin receptor, and blocking with RNA-related methods the production of angiotensinogen. These new drugs seem to be very interesting and promise a better control of hypertensive patients, but we have not to forget drugs that are already available, such as SGLT2 inhibitors or sacubitril valsartan, which can reduce blood pressure values. And finally, renal denervation is a good option for those patients who don't take drugs because of a low compliance, for the side effects, or for the low adherence. And however, this is just a brief overview of the webinar that with distinguished colleagues will discuss in more deep all these issues. And I hope that you will be with us. I remember the date, Friday, 20 June 2025, to approach this important issue related to hypertensive treatment.